Before we begin, Stroke Foundation respectfully acknowledges the traditional owners and custodians of country throughout Australia and acknowledges their continuing connection to land, water, sky and community. We pay our respect to the peoples, cultures and elders past and present, for they hold the memories, culture and hope of their peoples. I would like to acknowledge too that I'm joining you today from the lands of the Wurundjeri people of the Kulin Nation. Good evening, everyone, and thank you for joining us tonight for this really important webinar on stroke management in general practice, specifically in ACT. We have some really fantastic speakers for you tonight, so I have no doubt you'll find this session extremely engaging and informative. My name is Belinda Bullis, and I am the Community Engagement Manager at the Stroke Foundation. Now, more than 80% of strokes can be prevented, so general practitioners like yourselves are ideally placed to help prevent strokes by identifying high-risk patients, educating them to recognise signs and manage their risk, as well as providing early interventions and referrals to other specialists and services, and implementing rapid action plans in the event of a stroke. This event is brought to you today by Stroke Foundation in partnership with Capital Health Network, supported by ACT Health Directorate. We hope this webinar supports you and your practice staff to save lives and improve long-term recovery from stroke. Now, before I introduce you to our presenters today, I will be doing a quick poll and we'll run through some quick housekeeping as well. Housekeeping first, an interactive webinar is a good webinar. We really encourage you to use the Q&A function at the bottom of your screen to submit your questions as you think of them. Use the Q&A function rather than the chat if you can. We will answer questions in the second half of the session towards the end. If you see a question that someone else has asked that you also want answered, you can click the thumbs up button under the question to vote for it. Now, we will be running a quick poll on stroke tonight, so I will now give you 2 minutes or so to complete these questions. You should have them on your screen now. Now, while you finish that poll, I would now like to welcome our wonderful speakers, Dr. Peter Park, Mr. Yoshka Strahan, Mr. Vijay Mandan, and Mr. Stuart Gregg. Dr. Peter Park is a consultant neurologist and clinical researcher at the North Canberra Hospital, previously known as Calvary Public Hospital Bruce. He completed his medical training in neurology at multiple tertiary teaching hospitals, including Royal Melbourne Hospital, Liverpool Hospital, and the Canberra Hospital. Mr. Yoshka Strahan is the stroke nurse navigator, overseeing the acute stroke nurse team at Canberra Hospital. He has worked as a member of the acute stroke nurse team for the past 2.5 years and has a special interest in stroke care and primary prevention. Mr. Vijay Mandan is a stroke liaison nurse at North Canberra Hospital with expertise in nursing and pharmacy. And finally, Stuart Gregg is a dedicated father of two from Victoria with over 20 years of experience in local government. In November 2020, at the age of 40, Stuart experienced a stroke. Recognising the fast signs himself, he promptly raised the alarm. This swift action led to a timely emergency medical treatment, which significantly aided his recovery. Now a stroke safe speaker for the Stroke Foundation, Stuart shares his personal journey to raise awareness about stroke prevention and the importance of recognising the fast signs. Through his talks, his aims to empower individuals to act swiftly in the event of a stroke, potentially saving lives. On behalf of Stroke Foundation and Capital Health Network, I'd like to thank our presenters for their willingness to share their knowledge and expertise with us tonight. We really look forward to learning from you all. Stuart, I will now hand over to you.
Awesome. Thanks so much, Belinda. And so it said, I'm really indebted to be in this virtual room with such amazingly important people. And I want to just start by thanking you all for the work that you do, particularly the docs on the screen that I can see. Yeah, Belinda's given away all my story, so I'm just going to just skip it. No, I'm not. I've got 10 minutes. I've got a timer on my screen, Belinda, so I'm going to try and stick to it because I am known around these parts as to be a waffler. Look, before I start, I also want to acknowledge that I come to you on the traditional lands of the Bunurong people. I certainly want to pay my respects to elders past and present. I want to extend that to any First Nations people on the call today. My name is Stu. as Belinda said, I'm a 45-year-old dad from Werribee in Melbourne. So if you know Wezza, rough area, and that's why I've got a beard just to get me through. Yeah, look, I'm a pretty ordinary dude. I'm a dad of two beautiful kids. Yeah, and I've worked in local government for 25 years. I was a youth worker for many years. I've worked in kindergarten services. I've worked in community centres. I've spent some time in a reconciliation lead role working with First Nations community. And I find myself now working in community as a community development area leader. So I work alongside my amazing community doing great things for our wonderful community. And importantly, I'm a stroke survivor as well. And very humbly, I'm a stroke survivor. So if I can rewind the clock and take you back really quickly to a glorious time of our existence in 2020, wasn't that just a gem of a year? It was November 26th. It was a Thursday morning. I got up to start work. I was working from home, as we all were, and had been for a long time. As I came into the lounge room and said good morning to my children, my ear made a really profound ring. It vibrated like you dropped a metal pole onto concrete. It went made this bizarre sound in my right ear. I play drums and I get tinnitus all the time. It was not that. It was very distinctively different. It echoed as I said good morning to my kids. And I looked at my wife. I was like, geez, that's pretty weird. Sat down on the couch and said, this is really crazy. Happened again. As I was leaning on the couch and I was looking at my wife over my left shoulder, I started to rock. I remember looking down at my chest and seeing my body move and thinking to myself, I'm not doing this. And that's exactly what I said to my wife. I was like, something's going on. I'm not doing this. The vibrating stopped in my ear, but I was shimmering it was like I was doing a daggy dad dance or something. I was moving like this. And she came around, my wife, and she put her hand on my shoulder. And so as she put her hand on my shoulder, I stopped sort of rocking. But as I went to talk to her, my mouth was glued shut and I couldn't make any sense of anything. I tried to talk and nothing came out. It was like the Matrix when he takes the pill. Nothing worked. And I remember at that stage, I knew I was having a stroke. And it took everything in me to blurt that out. I remember just pushing through my own mouth and I blurted out the word stroke to my wife and I blurted out the word ambulance. And so she quickly got on the phone and she called 000. And luckily enough, I was able to get triaged and taken into hospital. Ended up at Royal Melbourne. They certainly did a CT scan and saw that I'd had an ischemic stroke. There was a clot in my basilar artery. I was pretty promptly given the clot buster drug. It's got a fancy name. Don't know it. I know it as a clot buster. And it did what it said on the packet. It dissolved the clot in my brain. And unfortunately, only after 5 days in hospital, I was able to come home to my very concerned family. I'm extraordinarily lucky because I don't have deficit. I had some issues with my vision for the first 3 days, but that cleared up. I lost a lot of my peripheral vision, but that cleared up. Every now and again, I get blotchy eyes, but I think that's just because I'm getting old as well, And I like to say that I'm more forgetful now, but I know that I'm a 45-year-old bloke and we forget things. But in all honesty, I am one of the luckiest dudes to be able to come out of such an experience. So what caused my stroke was I actually had a DVT in my leg, which I didn't know about. But because I was working from home, doing long hours at my desk and hardly getting up, like I was doing a long haul flight at my desk every single day, meeting after meeting, join a meeting, leave a meeting, join a meeting. I developed a DVT and clearly that dropped a clot into my bloodstream and it got through a PFO in my heart. So I had a little flappy hole in my heart. The docs will probably tell you more about that. I just know it as a flappy hole called a PFO. And that's what caused my stroke. So following my stroke, following coming home, I had a couple of other little hiccups along the way. I had a TIA, a transient ischemic attack, about sort of, I was trying to think, was it 3 or 5 months later? So let's say about 4 months after that, I had a TIA, which got me back in hospital. They checked me out, but there was nothing that was obvious. So it was the same course of action. I was still on my meds. I was still sort of trying to, look after myself. It did bump me up the list. So I had my little heart flappy PFO hole closed a bit quicker than was anticipated. So in October 2021, I had my PFO closed. That triggered some atrial fibrillation about 4 weeks later or 3 weeks later. So I had an episode of atrial fibrillation. I think it was like a 1 in 15,000 chance. Lucky me. Which was quite terrifying to be taken into hospital with a heart rate of about 188 beats per minute, and it took about 10 hours for that to come down. It was bloody scary. As a result, I had some issues with mental health, in terms of just just feeling pretty low. But I'm a big believer in looking after yourself and applying the right things to mental health. So I spoke to counsellors. I wrapped my friends and family around me, and I did it. I exercised. I got out fishing, camping, and I got through that pretty unscathed. So I'm very thankful for that. I think the keys to success, the reason why I am so lucky, as Belinda said, is because I knew what was happening. I'd attended men's health programs before. The Sons of the West is a men's health program runs by the Western Bulldogs. And I'd attended that program. I actually facilitated that program, and I saw stroke safe speakers talk there. So I learnt the fast signs of stroke: face, arm, speech, and time. I knew the risk factors. I knew where I sat in the scheme of things with my own risks. And so when my stroke came, it was easy to recognise, even though some of those signs weren't the sort of standard ones. I was able to sort of put some things together and was pretty aware, and because of that, I was able to get that help that I needed. It wasn't long after I had my stroke and then I got home that I felt so indebted to the Stroke Foundation. I reached out to them and asked how I become a stroke safe speaker. I've been an MC for many years. I've played in bands. I've facilitated things. I'm good at talking crap, funnily enough. So I was like, let's turn that into something good. So I became a stroke safe speaker and wanted to give back. Becoming a stroke safe speaker was really helpful for me. It was quite restorative, if anything, and to be able to go and connect with community, be it community groups, schools, sporting clubs, organisations, and talk to them about all things stroke, about what is a stroke, the impact of stroke, the signs of stroke, the fast signs, the risk factors, and all the prevention that people can do, all the stroke prevention tips and tricks along the way. We talked about it. We often talk about all the confronting stats, and you'll probably no doubt hear some of those confronting stats today. They're really hard to swallow, but one of the best stats we've got is that 80% of strokes are preventable. And that's one of my favourite stats to talk about and share with the groups that I talk to, because the cold hard fact is I should have been one of those 80% individuals, but I wasn't. And it wasn't because I didn't take action when a puffy leg was staring me in the face. So I did all the wrong things. I was a stubborn 40-year-old dude who thought he was invincible. I blamed my mum's crappy circulation in her legs. If anything, I was like, well, mum's got crappy circulation, I've got crappy circulation. And I Dr. Googled it just to justify that thought, and Dr. Google backed me up. So I did the wrong things. So I tell people that in my stroke talks. And I talk in detail about the importance of the role of their GP. I talked about the importance of establishing a partnership and relationship with your GP. I talk about the importance of being honest with your GP, to go in there, ask questions, and tell the honest truth about where you're at with your health. I encourage their participants to see their GPs regularly, to get their annual health heart checks. I encourage people to be across their numbers, be it blood pressure, cholesterol, being on top of their atrial fibrillation if they've experienced it. I talk about, watching their weight. I talk about exercising, and heaven forbid, I talk about reducing alcohol intake. But I also, and mainly, or not mainly, I really strongly, from my experience, I talk about the need not to use Dr. Google and to actually go and see one of you fine people and actually have those questions. It's the thing that I should have done and I didn't. But I'm making up for it by spreading the good word. Look, I've got 55 seconds left on my timer, so I want to just finish by saying that I really want to acknowledge and thank you all for the work that you guys do within your communities and for the time that you've taken to listen to my story. And I really hope you get a lot out of this session. And thanks, Belinda, for the invite to join this forum today.
Thank you, Stuart. So inspiring, and you are such a valued stroke safe speaker at the Stroke Foundation. So important to listen and learn for people like yourself that have lived experience. So thank you so much for being so willing to share your story tonight. Please remember, to everybody, if you do have any questions for Stuart, pop them in the Q&A and we will definitely come back to them at the end of the webinar. I'll now hand over to Peter, Yoshka and Vijay.
Hello, I'm Yoshka. I'm the stroke nurse navigator here at Canberra Hospital. I'd also like to acknowledge that we're coming to you guys from Ngunnawal country in Canberra, and would like to acknowledge any elders, past, present or emerging, and any other Aboriginal or Torres Strait Islander people present. All right. So let's talk about stroke from a TCH and an NCH point of view to start off with. So today we're going to talk about a couple of different topics, some case studies, risk factors in general in stroke in Australia. We're going to talk about stroke outcomes, and assessing absolute cardiovascular risk, managing our risk factors, going back over a case study, and then do your staff and patients think fast, because it's really important. Here are our main learning outcomes that we would like to hopefully discuss and go over today with you guys. All right, so I thought I'd start off with a case study. So here we have David. David is a 63-year-old man with a history of AF, hypertension. He's recently quit smoking. He's called your practice to check in because he's had a bit of a funny turn. So David calls a practice and receptionist at 10 a.m. and reports a funny turn. On questioning, he said he experienced temporary slurred speech and left facial weakness that lasted about 10 minutes. He says he feels better now, but he no longer has a slurred speech, but he still feels a bit shaky and wonders whether he should make an appointment to see the doctor. What should the main response be? Well, it's our opinion that the main response should be calling 000 immediately and informing the response team that he may have a stroke. Time is brain floss. Now, if this was just a TIA, which is a sudden onset of focal neurological deficits that last on average about 10 minutes and will resolve within 24 hours and do not have any MRI evidence of a stroke, it still leads him at a very high risk of a subsequent stroke, and we want to work him up for his risk factors to prevent a stroke as much as we can. If someone has fluctuating symptoms or they're persistent when they do see you in the clinic, please get them to come into the hospital. And anyone who's had a suspected TIA should be commenced on secondary prevention, medication, and recommendations as soon as possible. Now, how do we kind of get our referrals for TIA in the ACT? Well, mainly it's through the emergency services, bringing them into the emergency departments. Here at Canberra Hospital, they'll either be admitted or we'll send them home with outpatient workup. On arrival, normally we'll get a CT angiogram, non-con, or Dopplers if they have chronic kidney disease in the emergency department, and we'll weigh up their risk factors, whether or not they need to be admitted. Then we'll follow up with an outpatient MRI, fasting blood form, and a heart bug, which I assume a fair few of you have got the reports from us. If the TIA occurred more than 7 days ago, you can refer them to the neurology clinic at either site. It'd be very helpful to start getting them some workup done, mainly some Dopplers, MRI, or CT if possible. Now, why is managing a TIA important? Well, we should be using our local policies because TIA is a big risk factor for someone to have a major, larger ischemic stroke afterwards. All patients, all their carers, families should receive information about TIAs, screening for diabetes, tailored lifestyle advice, and modification strategies, as well as they should be aware they cannot legally drive for 2 weeks here in Australia. And that they need to understand fast. They need to know what the signs of a stroke are. So if it happens again, they can come in as soon as possible. A person with a stroke has an accumulated risk of subsequent strokes of 43% over 10 years, with an annual rate of approximately 4%. Long-term management of these risk factors is crucial to their ongoing health, and the best person to help assist with that are our lovely GPs here in the ACT or around the country. Good communication between secondary and primary care centres is also absolutely vital. Now let's go over a bit of a hypothetical. What if, subsequently, whilst being transferred to North Canberra Hospital with ACTAS, David becomes aphasic and densely hemiparetic? The paramedics pre-notify North Canberra Hospital, and they are met in the emergency department by the stroke team. His NIS, which is the National Institute of Health stroke scale, score was 25 on arrival to North Canberra, and he was taken directly to the CT scanner. Now, how do we actually do acute stroke here in the ACT? Well, we have 2 different hospitals, one of which is a tertiary centre, the other is a secondary site. Here at Canberra Hospital, we can offer both thrombolysis and ECR, whereas North Canberra can only offer thrombolysis and then they'll be transferred to us. We're pre-notified by paramedics using a pre-hospital screen called CREST, which helps them identify stroke versus other potential cases. And ACTAS have our direct numbers here at Canberra Hospital. They can speak to the acute stroke nurse on site 24/7, 365, or at North Canberra, they get put through to a member of the North Canberra stroke team. Now, why is that important? Well, pre-hospital awareness of stroke and the ability to tell us what's going on as soon as possible allows us to make plans as quickly as possible. So ACTAS play a pivotal part in us being able to care for our patients as quickly as possible. Scanning requirements. On arrival, we'll normally be doing a multimodal CT scan, including a non-con, a CT angiogram, plus or minus a perfusion scan if needed. If needed, we'll also try and arrange a time-critical MRI, but we don't have the same kind of access to MRIs we do as to CT. CT angiograms have now predominantly replaced carotid Dopplers in the acute setting. We do Dopplers, but they tend to be as a second imaging modality if required by the surgeons. Now, after a CT scan, what are we planning for? Well, for us, it's our acute root perfusion therapies, mainly thrombolysis with a drug called alteplase, soon to also potentially be tenecteplase here in the ACT, or endovascular clot retrieval, which is a mechanical thrombectomy performed by one of our interventionalists here at Canberra Hospital. Now, approximately 35% of acute ischemic stroke patients may be eligible for thrombolysis, and approximately 30% of acute stroke patients who present with an LVO present within 6 hours of symptoms. The sooner we get to these patients, the better. CT, now going back to David. David's arrived at North Canberra Hospital and he's taken directly to the CT scanner. They performed all 3 scans, a non-con, a CT angiogram, and then a CT perfusion scan. On the left, we have the non-con, and we can see here what we would call a hyperdense acute sign in the M1 segment. Then when we look at the CT angiogram, you can see there's a cut-off in the M1. So this is a very large stroke that can be extremely debilitating. Perfusion scan shows there's a large amount of brain that's potentially salvageable, but there is a core. So the decision was made not to thrombolyze because David was anticoagulated before this and his symptoms, and there was already a core. David was then transferred directly to TCH, where he was taken directly into our angio theatre, where one of our interventionalists has put a catheter up into David's brain to pull out the clot, which was successful. Now, luckily for us, it was good, but we didn't have the best outcome. Unlike Stuart, we can't always get the outcomes we want, depending on how much time has happened and how people's brains survive. In this instance, David has ended up quite disabled with minimal improvement and will probably never walk again or be able to go home. So how could we have done this better? Well, he was already anticoagulated, so we're doing the right things. Sometimes it's unavoidable. But what can you guys do for the acute setting? If someone does present to your practice in person, assessment, history, and a quick exam before sending them off to emergency and telling us what's going on is pivotal for us to be able to treat them as quickly as possible. Now, going over towards more stroke in general in Australia, for a 45-year-old man, the risk of having a stroke by the age of 85 is 1 in 4, and it's 1 in 5 for women, so it's extremely high. It's the 3rd leading cause of death in Australia after heart disease and dementia. 440,481 Australians are living with the effects of stroke in 2023, and 2 in 3 of those survivors depend on another person for their daily needs. It's estimated that stroke costs approximately $9 billion. If we look at the outcomes of stroke within 6 months, for every 100 people who've had a stroke, 18 die within 6 months, majority within 30 days, 30 are permanently disabled, 8 in institutional care, 16 are independent but not able to do all of their normal things they'll do beforehand, and 38 little to no symptoms. So a large proportion are extremely affected. hemorrhagic strokes tend to account for a lot of the higher MRS brackets. Now, risk factors are what we really want to try and prevent. As you've already heard a couple of times, 80% of strokes are preventable, so we want to try and prevent them as much as we can. Between the two different strokes, ischemic strokes account for 80% of our strokes in Australia, and 20% are hemorrhagic, including subdurals. Now, we have some non-modifiable risk factors. These are set in stone. There's not much we can do to change age. The alternative isn't that great. Ethnicity is pretty much set in stone. Gender and genetics are set. All we can do is try and go off what we can actually modify, which Peter will be talking about a bit later, but here are the main ones. Now, what are the main other outcomes? Well, as we were talking about in the poll, regional and rural Australians are 17% more likely to suffer a stroke than those living in metropolitan areas. And regional and rural Australians are also more likely to die from stroke or be left with serious disability because they don't have the same access that we do in metropolitan areas. I don't think I need to go over all the major kind of long-term effects of stroke, but it's not always just the weakness that affects people or their ability to communicate. Some people can become extremely depressed or anxious after a stroke, suffer from chronic fatigue, emotional dysregulation, incontinence. These things aren't as obvious to maybe the general public as just the weakness. All right, I'll hand over to Peter Park, who will go over the next couple of things.
And we're going to wind the clock back by just a year. So this is David when he's 62, just 1 year before the stroke that we just seen on the screen just before. So David had just moved into Canberra and he visited your practice for the first time. And luckily, like Stuart, he has been to one of Stroke Foundation's community talk called Stroke Safe. And so he requests a heart health check. So we'll go to the next slide. I think I'm probably preaching to the converted here already. And thank you really so much for all your hard work in terms of the heart health check, which has the MBS item of $699. And I think, look, to be very honest with you, this was my first time hearing about this, preparing for this talk with the Stroke Foundation. And I think it is such a great initiative that you get to spend with your patient for at least 20 minutes going through a number of pertinent key risk factors in terms of history and examination, particularly about diabetes, alcohol, smoking, blood pressure, and cholesterol. I think they are really important things and imperative things for our patient care. Not to mention, I mean, the checking the pulse manually to assess for irregular heartbeat being quite important to detect AF as well. And obviously, as part of this consultation, you'll be initiating different management plan that will include different tests and referrals, which is very important. Applying this heart health check to David, he mentions that he's worried, and that's the reason why he's here, because his father, around his similar age, had a stroke and was partially disabled and was dependent on David's mom. His father died when he was 62, exactly the age that David is in. So we explored the history examination, and from a history perspective, he's got a few definite risk factors that includes alcohol, ex-smoking history, sedentary lifestyle, as well as significant hypertension and normal pulse. But obviously the waist to hip ratio and BMI could be further optimized. And he further comes back for a review consultation with you once the pathology test comes back. And he has also had a chance to take his home blood pressure as well. And I think he identified clearly that his cholesterol are above target, even for primary prevention perspectives. His blood glucose levels are in the pre-diabetes range. And although his office blood pressure again is significantly elevated, his home blood pressure is elevated regardless, although slightly better. And pulse again is normal. So coming back to David's risk factors, I think if we were to have this checkbox, we can tick a number of them, including, I think, the ones you can see on the screen. Obviously, there are some non-modifiable risk factors, or some of the risk factors that we don't routinely check for. I think including the apolipoprotein as well as genetics. So the key question here is to ask, what kind of risk is David at, and how can we assess for it? I don't know if any of you have used this tool before. There is this risk factor tool that we'll be talking very soon. And it's really pertinent because 1 in 2 persons that you come across in Australia, they will have 3 or more modifiable risk factors for cardiovascular disease. And that is a huge number. And as Stuart has pointed out, it just shows how important it is to really ask and assess for it in each individual patient, because 1 in 2 persons or even more will definitely be bound to have 3 or more risk factors that's modifiable. So what do we have? We have this Australian cardiovascular disease risk calculator. This is based on a, I think, study called PREDICT, which helps you predict the cardiovascular event over the next 5 years. It's applicable to mainly adults above the age of 45 to 80. There were some special populations, including Aboriginal and Torres Strait Islanders, as well as people with diabetes. And so, however, most of the people will be applicable to this risk calculator tool. I think we'll go through some examples now. So if we were to apply this to David's, given all the risk factors that we talked about, and if you plug all the numbers in, it will return significantly high. And that, what we mean by that is there is a 5-year risk of 70% of cardiovascular disease, including heart attack and stroke. However, what's amazing is that if you identify this through that consultation that you had, and if you initiated antihypertensive therapy and he returns and sees you in the next 3 months, and his blood pressure systolic blood pressure comes down to 140, with cholesterol level dropping significantly, you can reduce the risk to 9%, which is thought to be much lower risk in terms of the cardiovascular disease. So what we can do in that clinic room is significant, and it makes huge impact for patient care. So how do we modify and manage absolute cardiovascular disease risk factors? The key message is that managing several risk factors at once to a mild to moderate degree could be more significant than just addressing one at a time. But to be very frank with you, I think you will need to pick and choose and decide who your patient is and really target interventions accordingly. Some patients don't want to take more than one medication. Some patients want to do every single thing. And this is a summary slide talking about, oh, sorry, Yoshika, we'll go back to that slide. This is a summary slide talking about how your approach would be different based on the cardiovascular disease risk. For instance, for those in high, moderate, and low risks, I mentioned here. Next, couple of slides have got quite a significant amount of detail, and they've been prepared by Stroke Foundation and ourselves today. And rather than bombarding you at 7:30, 6 p.m. with all the information, what we decided to do is this is being recorded, so we'll leave it for your reference. So there are a number of things that can be done in non-pharmacological and pharmacological perspectives for lifestyle. And next slide, we'll talk about what kind of physical activity you can do, diet. Obviously, there's many things you can do, which you're, I think, quite well aware of. smoking cessation, I think you're much more of an expert than myself in all this, as well as I think alcohol reduction, hypertension, and there are key targets and key numbers you can take away today from these slides. If I can mention something about hypertension, I think key thing is aiming systolic blood pressure and diastolic blood pressure to those targets of 130, 140, and 80, as you can see there. And you may need more than one antihypertensives. And I think this is another slide showing diabetes and different resources you can approach to get updated about number of key factors there. Now, I did want to spend a little bit of time on this slide, and this is I think close to many of stroke physicians and clinicians' heart. It's about atrial fibrillation. And AF is, I think, relatively prevalent in community. I think we do have many patients. I'm sure all of us have different patients with AF. And I think we know about the risk classificating tool called CHEST-VASc, or even all-day CHEST. And that the key treatment is direct-acting anticoagulant, not warfarin, but the NOACs are preferred nowadays. What we really want to talk about is how anticoagulation initiation in the community can be challenging, and partly I think that's because some of our patients may not have all the information ready with them. They may not be with their loved ones or family members who can give the corroborated history. And I think what's problem is that people may have had few falls, or they are deemed to be at a significantly elevated risk of falls, and their anticoagulation stopped or not started. And unfortunately, they do come back to the hospital with a huge MCA stroke, which debilitates them significantly. So someone who was living at home with a little bit of falls freaks, for example, may end up in a situation where they're talking about going to nursing home when they're 60 or 70. And that is, it can be a significant problem. But I think we are all in that, we're the gatekeepers in terms of potentially being able to prevent that significant stroke and comorbidity and, I guess, disability that can result from the stroke. So I think this is one of the key slides that we wanted to highlight today. Obviously, there are many other important risk factors that we didn't get to touch on, but there are a number of resources you can use in your own time, and they will include lipids, alcohol, as well as obesity management. Now, so we come back to David's management. So we established that he is at significantly high cardiovascular event, about 70%, using that Australian calculator. And we have decided to initiate different antihypertensive therapy. And we would have started one ACE inhibitor or ARB, and knowing that he may need to come back and then we may need to start another agent in the next 3 months. He's also been started on a statin as well as the lifestyle modification. Now, so we come to another hypothetical here. This is saying David 1 year before the stroke, and he's now diagnosed with AF. And he is actually a current smoker. So how would that change our management further? I'll leave the slide a little bit longer and we'll go to the next slide. Yoshika, we can go to the next slide. And I think this is time to just reflect about how does AF affect David's risk of stroke? What are the key factors that you would consider in thinking about what to do for his AF? And what advice would you give to David about smoking? This is cat out of the box very soon, but I don't think the Zoom environment will allow for the more didactic, interactive session. So apologies for that. But I think in David's case, obviously, in addition to all the lifestyle, hypertension, and cholesterol management that we've done previously, It's about having a really open discussion with David about atrial fibrillation and how his risk is chest vascular 1 at this point of time when he's 62, and that the anticoagulation can be considered to reduce the stroke risk. And obviously in this case, David did agree to initiate the therapy with the bigatran. But any delay is fine, the bigatran, apixaban, or rivaroxaban. And you would consider starting pharmacotherapy for rate control. And he was given atenolol for hypertension and rate control. And I think you would provide smoking cessation resources and advice so that he can reduce and potentially quit smoking. Last slide from me. So I think another key message that we always think about is how can we optimize our patients' ability to keep taking the medication they need to take. And I think it is really a challenging role and challenging space that all of, I think, yourselves are in, given that really the carrot is not apparent. Whereas I think secondary prevention can be, I guess, somewhat much easier to achieve in certain ways. But definitely there are a number of key factors that can be considered from optimizing adherence. And I think that's really important, given that really you can have the best treatment out there, but if you don't take it, it's the same as not having it available. And I think it's really important that we all together work on achieving better adherence for our patients. And I think that's easier said than done, but a very important space to be in to collaborate. And I'll hand over to Vijay.
Concluding words. Okay. So we'll start with that. Time is a brain. It's not just a slogan. It's a biological reality. With every single minute that passes out without treatment, the patient with the ischemic stroke loses 1.9 million of neurons, which makes up 14 million synapses, 12 kilometers of myelinated fibers. That's an enormous amount of the brain function vanishing minute by minute. This is why thrombolysis must be given as early as possible to the eligible patients. Ideally, within the 9 hours of the symptoms onset or sooner if possible. If we act quickly enough, thrombolysis can restore the blood flow before irreversible damage occurs, preserving not just the brain tissues, but a person's independence, communication, and the quality of life. So this message is clear. Every minute matters. Early recognitions, early response, and early treatment are critical. Stroke is a true medical emergency. Timely interventions can make a dramatic difference in outcomes. Treatment like thrombolysis and endovascular cord retrievals can restore blood flow and a significant improvement in the recovery. This all can be achieved, but only with the delivery of this medication as early as we can. These therapies are time dependent. Given within the 4.5 hours to 9 hours since the starting of the symptoms. But endovascular cord retrieval can be performed within the 24 hours of onset of the symptoms. However, only 38% of the Australians with the stroke reaches hospital within the 4.5 hours of the stroke onset, which is a critical window. So the key question for us and for the GPs will be what we can do to help the remaining 62% to get the patient faster in the hospital. So we have to identify the barriers over there, which contribute in the 62% of the patients in the community or stroke people. There are several pre-hospital barriers, which are like lack of community knowledge. They are not aware of the signs and symptoms of the stroke. The stroke sufferers are mostly calling the medical professionals, not calling ambulance fast enough to come to the hospital. Either they are also using their own private transport to come to the hospital, which doesn't allow the hospital to act fast, rather than calling an ambulance. People are also ignoring the symptoms and not seeking for more help for that. Either they are presenting themselves to the area where there's no stroke unit. So as a primary care provider, we should often the first line of the contact in the hospital. The people should be aware to call 000 immediately when they observe any symptoms. Now the awareness of sign and symptom. People are generally aware of the heart attack symptoms and they are acting fast and calling for help. While if we look at the stroke, people are not aware of the sign and symptoms and their awareness is very low compared to the heart attack, and they are ignoring the symptoms, which is very crucial for us in the community because we can't act fast on that level. So the GPs comes there and play a very important role. How they can help us in that? During the routine checkups, while the risk assessment for the patients, or even casual conversation with the patients, can provide them more education and they can act fast on that. Do your patients and the staff think fast? Let's say the FAST is acronym, which used to find out the basically large vessel occlusion, which is a kind of a stroke. As the acronym says, it's F for face is droopy. There's a weakness in the arm, either in one arm or the both arms. Speech, which is slurred or confused, they are looking for the words. It also can impact on that. And the time, which is critical. They need to call 000 immediately, which should be a patient should be aware of this one if they notice any one of these signs. Sign and symptoms of the stroke and TIA. When it comes to recognizing a stroke and TIA, we must act fast, as the word says fast. Or 80% of the strokes will show at least one of the fast signs, which are facial weakness, arm weakness, slurred speech. But we shouldn't be limited to this one. There are other factors also showing up the stroke, which are sometimes hard to pick up, which are there like weakness, difficulty in speaking, dizziness, headache, difficulty in swallowing. We hardly assist in the community for that, but these can be also the symptoms of the stroke. Now come to the education, because it's an important tool and it's a very powerful tool in the community. First, it's essential for all members of the practice to be aware of the signs and symptoms of the stroke. Early recognition of signs and symptoms of the stroke can direct them to the right way. Also, asking the right question from the patient who calls to the practice with the signs and symptoms. And we have to act fast. Ensure we guide them to transfer to the hospital urgently. This is for the staff, but also there's a patient plays an important role as well who suffers from the stroke. They should be educated regarding what are the risks for the stroke. Same as the practice part, it's also they should know what they look for. How they should be confident to calling ambulance rather than any primary care physicians for that. And clearly tell them the emergency services, like they should be suspecting a stroke or TIA, so that ambulance can act fast as well, and they can pre-notify the hospital for their treatment. Now come to the fast resources. There are plenty resources available. The Stroke Foundation offers variety of these materials, which are on the screens. They can be found on provided link over there. It's easy to get on that. It's easy to distribute to the patients. It's also helped with any kind of events or community or charity, like a webinar or any kind of in-services. They also help this one if someone have it on board. There's also the prevention flyers, which also help the patient education as well. It's very, really helpful for the patients and for the practice as well. These simple tools can make a huge difference in raising awareness and prompting faster action. So now the take-home messages. To wrap up here, there are the key home messages for us. Stroke is a medical emergency. Every minute counts. Up to 80% of the strokes are preventable. Please, heart health checks, use that things to identify the risk factor for the patients. And call the ambulance up to 24 hours of the onset of the symptoms. Let's continue to empower our patient to recognize stroke signs early and respond fast. Together, we can improve outcomes and save lives. Thank you. To hand over to Belinda.
Thank you so much, Vijay, and thank you to Peter, Yoshka, and Stuart as well for such an important and informative presentation. I can see a question coming through the Q&A, so please feel free to everyone to type your questions for our presenters tonight in that Q&A box. I think from my perspective, I might as well open up the Q&A with my own question, which is directed to Stuart. Now, Stuart, what has been your most heartbreaking observation of stroke that you have? And this might be either from a personal perspective or from a wider community perspective, what that heartbreaking observation of stroke might be.
Wow. Geez, there's unfortunately there's lots of heartbreaking observations to be made in the stroke space. I mean, the impact that it has on all facets of your life and your family, friends, your work. You know, and again, I'm one of the lucky ones, but you know, during my journey at the Stroke Foundation, certainly have met amazing people who are, you know, fighting every day. I think that's really and the fact that stroke impacts young people, you know, stroke impacts children, you know, stroke is always reminds us how devastating it is. You know, and again, that's why the importance of knowing the signs and acting as quickly as possible. I really appreciated sitting in this session today to hear, you know, what can be done, you know, before in the prevention space, but also in that sort of golden 4.5 hours. You know, there's so much to be done, and I didn't realise, you know, that you know. After getting the clot buster, the thrombolysis or whatever it's called, clot buster, that can restore, and clearly that's probably what's happened to me, possibly. But yeah, it is super devastating, and I think there's also this. There's this bit about this stigma as well, like about acting. You know, like people are nervous about calling ambulances. One of my friends and colleagues, who's also a stroke survivor, when he had his stroke, he did Dr. Google. He did Dr. Google, and even when it was saying stroke, he didn't believe it, so he changed his symptoms until it said something else. So I think there's, you know, this men's health thing, we put our head in the sand as well. So I'm going off on a tangent now, Belinda, so I'm going to shut up. But there's so much, but also we've got to remember there's so much amazingness in this country. We are leading in stroke care. So that's the bright side.
Stu, whilst you're on a roll, can I ask a question about about Stroke Safe? I think you talked about how you attended the talk with the Western Bulldogs.
Yeah.
So I was with Collingwood when I was in Melbourne, but don't put it against me. But yeah, what's the Stroke Safe, And
Well, yeah, it was a stroke
and-
safe talk. So what we
Yeah.
do as stroke safe ambassadors and stroke safe speakers is we do these talks. And so I saw a stroke safe speaker, a stroke survivor, go to the this men's health program, which was through the Western Bulldogs, which was called Sons of the West. And that was a men's health program that talked about a whole range of health health issues and conditions. They talked about cancer, they talked about heart health, they talked about stroke, they talked about mental health, they talked about social health. It was a really amazing program. But that stroke presentation, as I mentioned, was a stroke safe speaker who came out and they talked about what is a stroke, everything we sort of heard about tonight, but in way simpler forms. What is a stroke, the impact of stroke, signs of stroke, the fast messaging. So it was because of that I was very aware of what was going on for me. Again, I was one of the lucky ones because I was informed, funnily enough. Again, us blokes, we can be stubborn and not be informed, but I was luckily very informed. Thanks, Peter.
See, Peter and Yoshka, a few questions coming through in the Q&A box. Would you like to answer them now?
So Peter, please comment on approaches for a patient who's had a previous hemorrhagic stroke who later develops AF or who concurrently has both. What can we do?
Well, Dr. Tracy Baker, I think really, really very important question. Thank you for that. And I think I can see that this is quite a tricky question, but I think one of the key things that we need to know to answer that question is how long has the patient since a hemorrhagic stroke has been? And second question would be, what was that hemorrhagic stroke caused by? I think that's quite important because a 70-year-old man who had subdural hemorrhage after hitting his head while fixing his car, because he felt dizzy and just fell backward onto the brick wall 10 years ago and had no subsequent sequelae, is very different to someone who just had a intracerebral hemorrhage in the setting of severe hypertension, uncontrolled hypertension from the back in the community, despite different, maximal therapy or like good efforts. They are two different populations. But I think the key message would be really checking the detail of what hemorrhagic stroke it was. That would be one key thing, and working together if needed be with the local neurology team in public or private setting to clarify the risk and have a discussion about the benefit and the risks of anticoagulation in the patient. I think it would be one of the key things to do. And please let us know if that doesn't answer your question, but I think it's a tricky question. It depends on the etiology and the duration of time. I can see the next question is from Dr. Ashish Ahuja. Sorry if I didn't pronounce it correctly. So I'll read the question out. In David's case, despite DOAC, he had a stroke. Does it mean that anticoagulation was not sufficient? Maybe inadequate hypothetically? Could we still consider thrombolysis? A great question. And maybe Yoshka, I mean, would you like to take this question?
I'm happy to have a talk about this. So this is more coming into, especially when we go into the more up-to-date current research in regards to thrombolysis and stroke. There is evidence to support that thrombolizing someone on a NOAC is as safe as someone who is not on a NOAC. It's still something that at Canberra Hospital, North Canberra, that we're moving towards. Eventually, we'll see where we end up. But at the moment here at Canberra Hospital, if someone is on a NOAC, we're taking, especially apixaban or rivaroxaban, we're taking anti-factor 10A blood levels, and then based off the results of that, we can potentially thrombolize them. And it's not always in regards to whether or not the NOAC itself has failed. It could be that a NOAC was paused for an amount of time, either pre-op, or in the case of some patients, even on maximal therapy, they still have left atrium clot formation. In that instance, you could then consider left appendage closure and stuff. But at this instance, we're getting to the point where I don't know how much prevention we could really expect. There's always the risk. It's just trying to lower it as much as possible. Coming to mind, there are a couple of patients recently who were on maximal therapy in regards to fully anticoagulated, and they're still having strokes. But they can be considered for thrombolysis, pending blood results and imaging. And if it's an LVO, it's probably safer in some instances just to go straight for clot retrieval. What do you think, Peter?
I think just to answer that question directly, though, I think DOAC is never bulletproof. I mean, no treatment is bulletproof. I think that's important to say. And even despite best efforts, people can have stroke. And David is a pseudonym, obviously, and it is actually a real patient case, except we tweaked a few things so that it fits the presentation today. But it was a wake-up stroke in this person. This patient did take medications very, very strictly. But however, there are rare breakthrough and despite the anticoagulation. They can happen in a few instances. And obviously adherence is the key issue to nut out. And we do check the DOAC levels nowadays in the hospital, in very urgent settings. And some people, despite saying that they were taking it every single day, the levels are low, and we do ask them again, and they do say that they could have missed it for 1 or 2 doses. So adherence is really a key issue. And obviously there is thrombophilic state like cancer, which can also cause the problem too. The evidence, so really it's hard to say what is the best thing to do if you do have a stroke despite therapeutic level anticoagulation. And as Yoshka said, I think direct endovascular retrieval, if you have large vessel occlusion, something that we do. There are some debates going on about whether you can actually thrombolyze these patients or not. And I think you would potentially come across patients who were reversed of their anticoagulation before they are thrombolized. So I think you would know about the bigger trend.
The bigger trend.
Yeah, would have idarucizumab, which is a reversal agent that people can get, and some people have thrombolysis on top of that. But there are some debates about what is the right way, and currently there is some move about doing the drug levels and thrombolizing if the levels are low. That's currently where we are at this point in time. The next question was comment about lipoprotein A levels in stroke and any management strategies, and that's coming from Dr. Kui Lian. Thank you for a very sharp question. And one thing I really want to say is that Stroke Foundation generously provided the PowerPoint for us, and it was really not our intention to include lipoprotein A level in the risk factors, but it did go. And look, it's long story short, that yes, I think lipoprotein A increased levels seems to be associated with stroke. And as we know, lipoprotein is another form of the lipids which we have, and it's mostly genetically. I guess it is really got a huge genetic influence which we can't control, and there are no known treatments. So really in day-to-day clinical practice, this is not something that we don't deal with. And so we don't check this lipoprotein level. We do check DOAC levels, but we do not check this lipoprotein levels. So I think we probably can put that aside for now. And hopefully Dr. Lian will be able to answer the question in next 5 to 10 years time, but I don't think we're there yet.
Outpatient TIA workup. So I'm happy to start talking about what we do here at TCH. So most of the time we'll either, depending on couple of different tests, we'll either admit or we'll send people home from the emergency department. If we do send them home from the emergency department, they'll already have had a CT angiogram done on arrival. If they have high-grade stenosis, we'll normally always admit. After that, we normally send them home to have an outpatient MRI, which is bulk billed through the hospital. done at IMED here at Canberra Hospital, because we can get it done faster than doing it here. If they're put on the public wait list, it would take a lot longer. Then we also organise outpatient bloods, mainly looking at HbA1c, fasting lipids, and fasting sugar. We also do what we call a heart bug here at Canberra Hospital, which is a 28-day long single lead heart monitor that connects to someone's mobile phone. It's bulk billed for the patients, so all of it is really just the workup. The only thing that we normally don't organise is a critical echo unless they're young. Most of the time our young patients would be admitted for workup and they'll get an inpatient TTE. We try and get as much done, but for certain patients, we just don't really have the capacity to get echoes done in a timely manner. And then they'll be followed up in our TIA clinic. I think our current wait list is a bit longer than our goal. We try and aim to see people within 4 weeks. I think in actual fact at the moment, it's closer to 5 or 6. But we do get them in as quickly as possible. And we give them targeted education about their risk factors before they leave on how we can help. If they're admitted, we'll normally get an MRI done as an inpatient. And depending on different factors, they'll get an echo done as an inpatient as well as the rest of the workup. The heart monitor will normally send a copy of the report to the GP practice on their DHR folder, so you get a copy. And with a heart bug, if we do find any arrhythmias, we're able to contact the patient. If they have found paroxysmal AF, we'll start anticoagulation as soon as possible, contacting the patient whilst they're still at home. So it's quite beneficial for patients in a long-form cardiac monitoring.
I think, Vijay, it might be helpful if you just flesh out a little bit about the North Canberra side as well, and I'll make a few comments at the end.
Yeah, right up. So at North Canberra Hospital, our pathway is to, if they are TIA diagnosis, we mostly admit those patients, and we do the workout for them as after doing the CT scans and perfusion, we admit to the stroke unit, and we do the workout for their management, like a bloods, fasting bloods with the same like cholesterol levels, LDL and HDL, HbA1c, and other lipid profiles and everything. We put it on the cardiac monitoring as well, as same as like a stroke patients. So we treat TIA as a stroke, but we just do all these things and organize an MRI as early possibilities. But if they are very low risk TIAs, sometimes if we can't get an MRI quicker because we don't have a public MRI in our website, then we send them as a outpatient MRI request if the patients wants to leave because they are totally improved. But we do the workout in the hospital and we put a follow-up request at the NCH TIA clinics as well.
And the reason why I said I'll say a few comments, I think, thanks for asking that question, because I think it's quite important because there are some differences in terms of TIA management across North and the Canberra hospitals. And obviously that stems from the how obviously North Canberra was Calvary Hospital, public hospital, Bruce. And so there are differences and we are trying to, I guess, rectify that. So we will be having extended cardiac monitoring device called HeartBug put on our patients as they leave the emergency department after a TIA. That's one. And second, we are hoping to organize the MRI scan, like urgent MRI scan as an outpatient with a local provider, and the talks are in the way for North side residents. So that's currently in progress. So hopefully in coming next 3 to 6 months, we will have more good news for our patients, and that's something that we are working towards rectifying. And however, I think what's important to stress is that we do try to admit high-risk TIAs on the stroke unit at both sites, and that usually means that all the necessary investigation should be done. And if it's not, please let us know through the GP liaisons of both hospitals, and we're more than happy to I guess, address some of the concerns that arises. And we have listed our contact details in the thank you slide, as you can see, and we're more than happy to answer any questions and that can arise from that. And I think we have got 2 more questions. So the next one is, I think, situation where I have seen a patient who having a stroke when surgeons have stopped the anticoagulation for longer than recommended time. Do you run education programs for surgeons? I think that there are particular surgeons mentioned in the questionnaire. I think the answer is it would depend on the site of this where the surgeons are operating. So particularly public hospitals, they are obviously have different layers of oversight, and we do have we do work closely with our surgical and anesthetic teams. And when the stroke risk is identified as a potential problem, in addition to following the guideline that we have in terms of when and how long to stop the anticoagulation for, we may be reached out to provide some further advice in case-by-case discussion. So obviously we do have less of that when the patients are more in the private space. But I think it's important to recognize that the surgery itself is a definite thrombotic challenge, and it does expose our patient to I guess, significant risk of stroke. And I have seen patients, despite following all the single line of the protocol, and despite having done so, having had a stroke, which has been devastating. And I think it's very tricky time, and really working together as a whole team is really important to address that.
Okay.
And I think I'll read out another question. So in terms of anticoagulation, how important is it to differentiate thrombotic versus embolic stroke? So I think examples are cholesterol embolus versus blood clot.
I mean, at least coming from TCH, we can run clot testing post-clot retrieval. The main thing we do is work up risk factors. So I think regardless of the fibrin content of the clot, if someone has AF, they're at a higher risk of stroke regardless. We don't routinely run clot morphology. We do occasionally, especially in younger strokes. But if we want to talk about that, we could do a presentation on ESOS. That'll probably take about the same amount of time. I think regardless, if they warrant anticoagulation, we will always recommend anticoagulation as long as there aren't other major risk factors.
I can add something to that, Yoshika. I think the main question is, what is the right way to treat different kind of, I guess, different kind of stroke based on the histopathology, and we are not there yet, as Yoshika said, and it is in the research space. There are some research outputs talking about certain clot characteristic having easier, I guess, being easily managed with thrombolysis or clot retrieval. There are different number of publications about that. But in terms of what we do in general as clinicians in day-to-day practice, I think if you don't have cardioembolic source, technically by guideline, you cannot prescribe a DOAC. Usually, and rightly so. So if you have large vessel disease, if you have small vessel disease, or even dissection as a cause of the stroke, the best thing to do is antiplatelets. And you start with aspirin and then clopidogrel, and then do antiplatelets. So it gets escalated in that way. In terms of anticoagulation, obviously that would be that is if you have atrial fibrillation as well as some other sources of cardioembolic strokes. And so I think that's really important to remember.
Because there have been there was I think a study last year about ESUS or embolic strokes of unknown origins and whether anticoagulation versus just antithrombotic therapy. And it found that antithrombotic therapy was superior. So it's important that we are prescribing the right medications for the right kinds of patients.
I think I'll have to take the next question to Dr. Baker asking another key question. So yes, I think the question is, teacher summaries sometimes ask GPs to order the MRI. There is no Medicare rebate for this in the absence of headache. And you're right, and in the absence of headache or seizures, I think that are the two criteria that patients can get Medicare rebates for. And correct me if I'm wrong. And look, yes, I think particularly my team at North Canberra, I don't know about the TCH, may ask GPs to order the MRIs. It's not all the time, and that's good to know that's reflected in sometimes. And that's mostly people being discharged from emergency department. And I think hopefully that will be something that we'll be able to rectify further with the impending protocol change at North Canberra for our Northside residents. That's something we are very eager to change, and hopefully that will result in better patient care. But definitely it is, we're aware of the problem, and we're working with Julie, I think our GP liaison, on this as well. But another thing we want to highlight is that MRI is not a prerequisite for review at the outpatient department at neurology clinic. So should you have someone you're concerned about TIA, obviously you can send a referral, but if you're concerned, you can, or you can email us. You can also call us if you're concerned too. Great to see more questions coming through. Yoshi, do you mind reading that question for us?
All right. Clot retrieval can be done within 24 hours. As was said, does it salvage brain tissue enough? Since clot busting window is 9 hours, and if it does help, then why can't we extend the window for clot busting therapy too? Well, this is something that's actually been talked about a lot in modern, journals and literature. Starting off, the window for TPA was small. And as we've gotten more kind of image-based, especially with advancements with CT perfusion imaging, that window has steadily been crept up and up and up to 9 hours. There is some literature support thrombolysis up to 24 at the moment, but it's still, I think, in a bit of the infancy, and it's a weak recommendation, only really in the case of a large vessel occlusion where you do have a large amount of brain that's potentially affectable. And just because the window goes out to 24 hours doesn't always mean that every single patient will still be a candidate within 24 hours. You can have two patients with the same occlusion with similar risk factors, and one person will just be able to have, better collateralizing flow from other vascular territories, which will preserve more brain longer. The window may say 24 hours, but it might be a lot shorter, depending where the blockage is and how poor their, flow from other vascular territories is. But there is some movement to push towards extending this TPA window out even more. Granted that the 9-hour window in itself was an extension from the 4.5-hour window. So I think we're still a bit early to implement that here, TCH. It'll take a bit more time, I think, before we'll be thrombolizing out to 24 if we end up doing it. And it's a tricky case. I think it's much more applicable in a large vessel blockage than a small vessel where you don't have that same amount of collateralizing flow. But we'll just have to see kind of where the literature goes. Peter?
Vijay, did you want to say something?
Understanding. There's nothing changed on my side.
Okay, I think No, I think if I concur with Yoshika, what Yoshika said. And well, I think the main thing is that I think one of the main key reasons why it's being extended up to 24 hours is there are wake-up strokes, and there are people with unknown stroke onset. They were found unwitnessed, collapsed, found next to the bin, found next to, by home themselves, and their non-con-CT looks great. And whether that's because of great collateral supply or not, whether it's because the stroke was recent at 7 a.m. instead of 7 p.m. last night, it's hard to say. But there are definitely different patient factors at play. But that's why the perfusion scan is something that we use, and I think our Australian stroke giants have somewhat pioneered a lot. So we do use perfusion scan to really identify those patients who will have salvageable brain tissue. We call that penumbra. And yes, it is possible to get a lot of the penumbra back. And so it's been a big game changer in the stroke space. And we hope that, it's about reperfusion. So it's about getting rid of the clot. So you're right that, it can extend beyond 9 hours for thrombolytic, because if you have the same environment of no significant damage on the seat, on the head brain, then you can argue for the same thing. Or why don't we do the thrombolytic to really address that? So I think, yeah, that's a great question.
How do you treat a patient with vasculitis as their reason for the stroke?
Vijay and I recently treated a patient with CNS vasculitis, isn't it, Vijay?
Right.
Tricky question from this anonymous attendee. For all the questions. So I think it's called source control. So yes, I think not short of providing the regular care of stroke in stroke unit, managing the blood pressure in hyperacute setting, providing antiplatelets. Really, one of the key things would be to control the vasculitis. And we recently had a young person in his 40s who was really fit person who used to be an athlete. And he presented with, I think, sudden headache and had outpatient MRI, or presented to emergency, had an MRI confirming the strokes and the vasculitis features. And so he promptly had all different kind of treatments. We couldn't thrombolize to retrieve him because there were no large vessel occlusions, or he did come outside the window of 4.5 hours. And he started getting quite a strong immunosuppressant with cyclophosphamide, high dose methylprednisolone, so that we can control the vasculitis. And he is doing okay. Obviously, it's still work in progress, and we are trying to prevent another stroke as the cause of the CNS vasculitis. Obviously, you may have other types of vasculitis causing the stroke, and obviously it's about source control, and that's really crucial. And it's about getting there very quickly, as quickly as possible.
There are an increased number of people asking for calcium scores. Higher calcium score may indicate a higher risk of stroke. So is there a role for aspirin anymore, together with reducing the obvious risk factors like high blood pressure, cholesterol, and smoking?
I'll take this one as well. I actually recently had to think about this too, particularly with the person with without the calcium score, but had all the risk factors. And then there was a question about, should I start aspirin? And I think the answer is use that cardiovascular risk assessment tool that we talked about before, because there are, I think, good amount of evidence saying that if you do have significant cardiovascular risk factors and you're in the high category, I think of more than 60% risk of the next 5 to 10 years, 5 years, sorry, then the primary prevention with aspirin may be justified. despite increased risk of bleeding. So I think there is a definite role of doing that. I'm not 100% sure on the calcium score. I'll have to look that up for you, Dr. Leanne. But I guess it would follow a similar logic. And I don't know if you have come across any literature talking about that. Maybe if you do, maybe put that up as a comment or the question, the Q&A, and we can have a chat about that.
I would still say though that continual antiplatelet therapy is the cornerstone of stroke prevention.
There's another question online, and I think it's another situation question. So a patient who was admitted a few days ago under neurology with TIA, and it seems like he's been discharged with a number of plans, including vascular review, referral, echocardiogram, Holter, PET scan. Would you say that they have been organized? I can definitely say that you can send an email to the respective hospital stroke liaison nurses. Yeah. Stroke navigator is Yoshka for TCH, and stroke liaison nurse is Vijay over there. We'll be more than happy to look into that for you.
We'll reach through the GP liaison unit.
That's correct.
If you do have any questions, I am always happy to have a chat and go over what's happening. As long as I'm not reviewing someone in the emergency department at the same time, but always happy to help improve care when we can.
I think the questions are still coming.
What is your approach to management of chronic small vessel ischemia? It's cardiovascular risk factors. Trying to control what we can control.
I think it's a common question that we, I think, referred for, and we try to answer as well, Dr. Perusa. So the question was, what is your approach to chronic small vessel ischemia? I assume that's what, by that, I think you mean white matter disease on CT or MRI scan, which can be of mild to severe categories. And they use this, I think, obviously a grading tool called the FRESCAT score. And look, I think we do say the three biggest differentials are small vessel disease, which is, I think, quite common with those with all the risk factors that we talked about. The next thing is migraine. Obviously in the right age group and right past history of migraine in someone who are middle or older age. And obviously the other thing is age-related change. And I can think of another one is obviously MS, and MS is definitely a big thing. And usually radiologists will identify whether this is typical or atypical of demyelination. And obviously those cases, particularly if it's challenging, will make way to us. But the key thing to do is really identify, is there any vascular risk factor you can optimize? And as we talked about, 1 in 2 person you'll come across will have more than 3 to 4 cardiovascular risk factors. And I think that's really important message to come back to. And 1 in 2 will definitely have cardiovascular risk factors, and it's about controlling them so that we can prevent further chronic small vessel disease, which can be a risk factor for dementia down the track should that progress.
Right. Now, next question is about CRAOs, central retinal artery occlusions. So central retinal artery thrombosis is considered a stroke, yet the follow-on workup is not as aggressive. Well, at least here at Canberra Hospital, as long as we know that someone's coming in with a CRAO or a brow, we do treat them like a stroke. Especially if a CRAO comes in and they've got complete monocular visual loss, we can consider thrombolysis within 4.5 hours. Due to the eye not having the same kind of collateralizing flow and it doesn't have the same reserves as the brain, you can't really use the extended window. but it is a thing that we can consider. When I say, if I get a referral from the opthal clinic that they're sending someone to the emergency department with a central retinal artery occlusion, we'll proceed to do a non-con CT brain and a CT angiogram. We treat the workup the same as long as we're aware of the patients and they've been referred appropriately to our department. So mainly we're looking to see, is this a potential cardiovascular cause? Is it, high-grade stenosis, caused from AF? And especially in some of our older patients, we're looking into the differentials of whether or not it's GCA. But most of our patients, even if they just have a crow or a brow, they'll get an MRI brain to make sure they don't have any small strokes as well in the ipsilateral territories. And then we'll normally also do a heart bug, all the same blood tests, and we'll send them home with a heart bug. So we do treat them the same ways if we're aware of them here at the hospital. And I think opthal and the emergency department are pretty good at sending them to us. The one area which I always find a bit difficult is I think a lot of people who do have, this sudden monocular visual loss, they tend to come in with a very delayed presentation. They're not getting to a stroke or neurology review within 4.5 hours. So by the time that we're informed of the patient, we're outside any kind of advanced reperfusion therapies. There were some trials about endovascular arterial thrombolysis locally, which did not show an improvement from medical management. There is some evidence to support thrombolysis, especially within 3 hours for a crowd with improved visual return versus just standard medical management with antiplatelets. But I like to think that we're treating our crow and brow patients appropriately and as aggressively as we can when it comes to work up here at TCH. But it's something that if you're finding isn't being referred to properly, or you find someone in the community who has a crow and hasn't had workup, you can always refer to the neurology department and we can assist with getting some tests done. I think the best way, do you have anything on crowds, Peter, or is that?
Oh, no. I think you answered it.
It's
you
something
answered
I've
it to
been,
full extent, Yoshka. And
it's something I've been talking about a fair bit recently.
and look, look, I mean, where I was before, I was at Liverpool Hospital, and like all the crowds and brows and any kind of visual change were referred to us as a stroke alert, stroke code, and we deal with that as a time critical matter. So I think that's really important message out there, and there's evolving space about thrombolysis in that retinal artery occlusion cases. So it's definitely something to watch out for. I don't know what you mean by aggressive workup, including doing every single thing. And sometimes it's not done that way, and that may not be the best practice, and that's but it may be to the multifactor. So if you have clear-cut, very big carotid stenosis, which is actually one of the most common cause of retinal artery occlusion,
we take them right for a CEA.
That's right. So you get the surgery for it right away, or stent, and sometime in those populations, some neurologists or the team may not choose to do echocardiogram, for instance, and because they have already done kind of cardiac monitoring as an inpatient and they did not find any significant arrhythmia. So obviously, I do like doing all the tests if I can, but it's about resources as well. And I think, Belinda, we are running out of time. Is that correct? I can see Belinda flashing over there. I think there's perhaps the last question
We
can
are a little
address.
bit, you can certainly answer that last question in terms of direct number to contact you guys on. Go for it.
I think if I may speak for my team, see, the only issue is that the direct numbers are, we don't have a direct numbers. I think that's the part of the problem. And we do, as you already know, and you've been through, the hospital system has many people going through it, of different seniority. So the best thing to do is look, if you call the hospital switch and ask for the neurology registrar or stroke nurse, if you're particularly worried about stroke cases, so Yoshika is stroke navigator and our VJ is stroke liaison nurse. Essentially, they are the first responders for stroke, particularly within the work hours. So please get in touch with that. And we'll definitely try to get back to you. And we have the emails up before, and that is one of the best way to get in contact with us too. And if you mark it urgent, we'll definitely look at it more urgently. So I think that would be no, the stroke nurses are well. Actually, the PCH,
actually, at Canberra Hospital,
yeah,
pending what my team's roster is and whether or not we do have coverage, we do have staff here at 24/7, 365, if possible. Granted, people do get sick. There are holes in rosters, but it does mean that if you have a call at 5 o'clock and you're worried someone is having a stroke, you should call us as quickly as possible so we can help assist with treatment. Our plan is we want to try and care for our patients as quickly as possible. And the sooner we know about them, the sooner we can alert the relevant people, the sooner we can get them to a scan, and the sooner we can give them treatment. And that's such a vital, crucial part of acute stroke care. And without having good referrals or the ability to receive these referrals, you just can't do it as quickly and as effectively as we currently can. And thank you all for continuing to care for our patients long after we've sent them off home to you guys. I always like to say we see them once in hospital, once or twice in the clinic, and then you guys care for them for the rest of their lives. So you guys are an invaluable tool to the ongoing care of these vulnerable patients who need this support. Thank you.
And on that note, we will end the conversation there. I want to take the time to sincerely thank all our wonderful presenters tonight for your invaluable insights and knowledge into stroke management in general practice within ACT. I hope this webinar instills confidence in you to take what you have learnt tonight and train your clinical staff and drive practice change in your clinics to prevent stroke and optimise outcomes for stroke patients. Thank you again to everyone and to everyone that's joined us tonight, and have a lovely evening. Thank you.
Thank you.
Thank you.